Okay. Good evening, everyone, and thank you for joining us. My name is Mirna Mohanraj, and I will be moderating tonight's live community education webinar on COVID-19, what the community needs to know. The COVID-19 pandemic is still raging, and this struck us as a prime opportunity to join with the community to share facts, answer your questions, and dispel misinformation about this virus. Tonight's event was born out of a new partnership between physicians from Mount Sinai Health System and Harlem Run, a local running collective who work to transform the lives of urban communities through passion, service, and curated fitness experiences. Through this partnership, we hope to bridge the gap between healthcare workers and the communities that we serve. I want to acknowledge and thank the phenomenal Harlem Run leadership before we begin for partnering with us. It's especially been a joy to work with Amir Figueroa, one of Harlem Run's co-founders. And before we begin our Q&A tonight, I'd like to invite Amir to say a few words.
Awesome. Thank you so much, Myrna. That was a great intro. And yeah, it's a pleasure doing this this collaboration with you. I know it's been really tough for a lot of people out there with what's going on. And I know it was really tough for us, what initially happened when COVID hit. And so I'm really grateful to do this this discussion because, as it currently stands, we are hosting group runs. And so people always have questions. And I thought it would be a great opportunity to kick this off with something everybody has questions about. So I really hope people can bring their questions, get them answered, and, we can all learn something and share everything today. So thank you so much for saying yes, and I'm grateful to be here.
Thank you. It's been an incredibly wonderful experience to work with you and with your whole organization. So we're going to get started. And by way of introduction, I just want to explain how the evening will work. We've recruited 3 of our expert physicians from Mount Sinai Health System to answer your questions this evening. Dr. Teresa Mack, Dr. Georgina Osorio, and Dr. Lena Miyakawa. Each panelist will share a brief overview of COVID-19 from their perspective, and then field questions from the audience. We invite you to use the chat function or the Q&A function to share your questions, and feel free to direct them at an individual panelist or at the group as a whole, and I'll be able to direct your questions as they come in. I'm so happy to introduce our first panelist, Dr. Teresa Mack. She's a primary care and HIV medicine specialist and the medical director of the Mount Sinai Doctors Faculty Practice. Dr. Mack is a champion for the underserved, providing quality healthcare to patients who may not have had access to healthcare. And we really are just so grateful to have you and your expertise here, Dr. Mack. And I'll share your slides now.
Okay. Thank you very much for that introduction. And I'm very happy to speak to the community. This is part of my passion. So next slide, please. So I'm going to talk to you about coronavirus disease 2019. It's also called SARS-CoV-2, which stands for Severe Acute Respiratory Syndrome Coronavirus 2. It's a respiratory illness that spread easily from person to person. And the first case was in December 2019 in Wuhan, central China. And COVID disease can be mild, it can be severe, and it can cause death. So how is it spread? It's through respiratory droplets that are released when an infected person coughs or sneezes, and this can land in the mouth or the nose of people who are nearby. The droplets may be inhaled into the lungs, and which are in people who are in close contact with each other. And close contact means less than the 6 feet apart. And so we have a COVID-19 nose swab test for current infection and the COVID-19 blood test for past infection. And this is just, I love this picture. Whenever I show it to the community audience, everybody goes, ugh. But if this is a person sneezing, these are all the particles. And you can think of that as being germs that are dispelled into the air. And if this is COVID, this can then you can inhale it if you don't have a mask or aren't protected. Next slide, please. So some of the symptoms are cough, fever, trouble breathing, muscle pain, loss of taste or smell, and dizziness. And some people with COVID may never have symptoms, but they can still spread the virus. And that is why wearing a mask is so important. Okay. I thought that there were a couple of racial differences that I wanted to bring up. African Americans and Latinx have over 2.5 times higher rate of getting COVID compared to whites. And it's almost a 5 times higher rate of needing a hospital stay. And the death rate for African Americans is 2.5 times higher than for whites. And Latinx are more likely to die than whites. And why do these differences, racial differences, exist? Well, Black and Latinx, they're more likely to have an underlying chronic illness. They may have poor access to health care. They may live in crowded areas, and they may not have access to many healthy food choices in their neighborhood, such as fresh fruits and vegetables. A couple of interesting facts. Pregnant women, they do have a higher risk for severe COVID-19 illness than non-pregnant women. And crowded places, close physical contact, and enclosed spaces, this increases the community spread of COVID-19, which is so important that we wear masks and practice social distancing. So how can you protect yourself? Well, you can avoid close contact with people, 6 feet social distancing. You can frequently wash your hands with soap and water and use hand sanitizer. Wear a mask. Change your gloves often or don't wear them at all, and get the flu vaccine and get the COVID-19 vaccine. I like this schematic, which is showing that if a person is a carrier for COVID and they don't have a mask, the transmission probability is about 70%. But if that carrier wears a mask and the healthy person does not, then the transmission probability drops to 5%. And if both wear a mask, that transmission probability drops to 1.5%. And this is why masks are so important. Can I have the next slide? And that I wanted to say, wear a mask, protect others. Thank you.
Thank you so much, Dr. Mack, for that great overview. We already have some questions rolling in from our audience, so I'll direct a few of them at you, and I'll invite you to answer, Dr. Mack, or Dr. Miyakawa or Dr. Osorio, if you want to pipe in with any follow-up answers or elaborations, please feel free to. So the first question is that, many of us in the New York community are already vaccinated. And the question is if we get a COVID infection despite being vaccinated, what are the symptoms that vaccinated people would get from COVID? What should vaccinated people look out for in terms of signs and symptoms after they've been exposed to somebody with COVID?
Okay, it's a great question. If you have the COVID vaccine, we have always said that it will protect you against a severe disease. It will protect you against hospitalizations and prevent death. You can get reinfected. I think the CDC has said that in people who have already been vaccinated, it's about 13%. And I have seen reinfection in my COVID vaccine patients who, and I'm based in Harlem. However, it is mild symptoms. And when I talk to them and I say that, they say, it doesn't feel mild, I feel sick. And I mean that you're not in a hospital. You didn't have to go to an emergency room, but your symptoms would be like a flu-like illness. And if you were without a mask in a closed area where everyone was supposed to have been vaccinated, that could have been your source. And so this brings up two important points, is that we should always wear the mask, whether you're vaccinated or not, and we should really continue to practice social distancing. So I would say that I have seen patients with upper respiratory tract infections not feeling well, a little tired, and they still do have the loss of sense of taste or smell.
Right. Thank you so much, Dr. Mack. Another question, and I have a young daughter who's going to be starting kindergarten, and I worry about this one too. So the question is, my child will be starting school in a few weeks. They're too young to be vaccinated. What can I do to keep them safe?
Okay. Yes, they are too young to be vaccinated, but in the home situation, you can make sure everyone else is vaccinated. When they go off to school, you have to engage in the school that they will have a mandate that everyone wears a mask, practices the social distancing, really trying to avoid overcrowding, and just being an advocate and a parent at that school saying, this is what we want.
Thank you, Dr. Mack. And you know, I'm already seeing, you know, in the New York City public school arena, already seeing incredible amounts of early planning, early communication to parents, ensuring that sort of pod planning for children so that they're in specific pods, specific classrooms with the educators moving less than the children moving. Really, I've been quite impressed. So if in your local school communities, you are not seeing that type of communication about planning and communication about sort of contingency plans, what happens if a teacher gets COVID? What happens if a family member gets COVID? What happens if a child develops symptoms? I really strongly encourage you to advocate for that type of information to be shared. You know, I think the New York City public schools are fairly uniform in their policies and practice, but certainly, as we see with many other city policies, they can shift and change neighborhood to neighborhood. And knowing that, especially in our region up here in Harlem, that we have many higher risk patients and families, you know, just strongly encourage you to advocate for this type of information and protections for your children. But just like the adults, mask up.
And, you know, that's a very important point, that you want to have the information if someone in the school is sick and has come down with COVID. That should be disseminated to you.
Dr. Mack, another question. So I'll just read this to you. Somebody is asking if they have, they're a healthcare worker themselves and they take care of asthma patients, and that they've noticed in 2 of their asthma patients that have had COVID before that one of the after effects after the COVID itself is resolved has been anxiety. And so the question is other than anxiety and potentially other mental health effects, what are the other sort of longer standing health effects that we may be looking out for or should be looking out for in patients after they've had COVID? And maybe I'll give an opportunity for Dr. Mack and then Dr. Osorio to answer that question.
Okay. I think the mental health and the anxiety and depression is really key. And I'm seeing that a lot in my patient population. They've been quarantined for so long. Some live alone. So that self-isolation makes the anxiety and depression more realistic, and people are scared to come out. In terms of the medical long-term complications, what I have been seeing in a lot of my patients is that they do not get their energy level back, or it's taking them a longer time to feel like they felt. And I'm giving a time frame of 6 weeks to 6 months. And so we tell them not to rush it. They may have to do rehab or pulmonary rehab or lung rehab so you can build up your lungs. You may have to do things to build up your strength because you're fatigued. You are fatigued and you're tired. And it's different than when I think we all would get the flu. It would be over in a course of 2 weeks, and we could go back to doing whatever we wanted to do. And that is not the case with this particular virus. So you need to make sure you're looking at all of your symptoms. The smell and taste usually come back, but maybe the dizziness will persist. And so we test for that, and you really have to be careful that you're not going back out and doing your exercises if you are not able to, if you're still dizzy, because you could have an accident.
Thanks, Dr.
Oh, and
Mack.
there are also, I'm sorry. And there's also, heart problems, but again, the ones I gave you are the more frequent that I have been seeing in the community.
Dr. Osorio, any follow-up to that? Would you like to add anything?
I think that I would, hi you guys. So what I would add first is just how sick was the person from the very beginning. So if they were very sick and they had to be in the hospital, one of the things that still strikes me to this day is that for many people, this was their first time in the hospital. And so that anxiety, that scariness is still going to be there, that trauma of coming to the hospital and being alone. The trauma of just being alone because you are having to be isolated and then not knowing what's going to happen, especially in the period of time that we really didn't know any treatments, things like that. So I think first is how sick was the person? And then if they ended up being in the hospital, if they were home, and then how sick also says how much the COVID may have inflamed that person's body. And inflammation, how severe the inflammation is that's when you worry about the heart and the lungs, and then how people can recover in terms of being able to, take steps and breathe and just not get short-winded so easily. But that brain fog and that energy, I think, was really for everyone, even people who had what we would say mild symptoms and maybe lost their sense of smell and taste and maybe stayed at home and just got some short-winded and recovered, and didn't have to go to the hospital. But that energy, I hear that a lot. And when you talk about energy and just feeling tired, we're talking about instead of coming back to things days later, it can take weeks for you to feel a little bit better. And so what I would just add is how sick was the person and how much was the virus able to inflame the body. And I think that's how you have to think about where the person can be in terms of recovery. And I have people who got sick last spring who still feel tired. And I think it's just being nice to your body and being kind to yourself and understanding what you went through when you got really sick. And I think that's what I try to stress to my patients, at least in the clinic and even in the hospital.
Thank you so much. To piggyback on that, Dr. Mack, another question for you. This audience member says, I feel mentally and emotionally exhausted. I live by myself. It feels like this pandemic will never end. What can I do to feel better? I think we can all relate to this question in some way.
Yes. First of all, I want to make sure that person has gotten the COVID vaccine and that they have spoken to their doctor and tell them candidly how they feel. Living alone, you're isolated. I try to tell my patients, you can still pick up the phone or the cell phone, and you can call people and just have some type of interaction. You still need to wear a mask, but you could go outside. You want to stay away from crowds. And if they are savvy, they can do Zoom support groups. But that living alone has really taken a toll. And we had never seen anything like this in our lifetime. And so we do have to address it when the patient does come to us.
Yeah, if I can jump in on this one as well, you know, I'm sure if anybody's on social media throughout all of this pandemic, we've been seeing, you know, the bread bakers and everybody engaging in all these sudden new fancy hobbies. And I think kind of a global, although it's maybe getting a little bit overused phrase is self-care. But I think there's a misconception that self-care has to be fancy and self-care has to be expensive or cost money, you know. And I think that's a really important thing to keep in mind, that self-care might be something as simple as setting aside some time to listen to music that brings you peace, brings calm to your soul and your mind. You know, doing something simple like preparing a meal over Zoom with a family member or a friend that you can't be near, that you haven't seen in a while. And I'd like to hear from Amir as well, you know, while we certainly want to do everything incredibly safely and masked, I do think that there are safe community initiatives that encourage fitness and community. And maybe Amir, you can comment about sort of your organization and the efforts that you've done through, you know, later in the pandemic and the safety measures you've taken.
Yeah, I'll quickly comment. I actually want to shout out a good friend of mine. He has an organization in the community. It's called Connect NYC. So they normally do a lot of roundtables. They used to do it in person. I actually attend them but it's a great support system. And they have like virtual meetings now. So in terms of building communities, I commend them for the great work that they do. And that's actually a community I dip into virtually, just to connect with men. And they also have women roundtables too, for anybody interested in that. But in particular to what we do in Harlem Run, you know, I definitely say, listen, if I have a child, so I'm very cautious now. So like if I'm around people, I'll wear masks. But you know, if you're outside, you know, I'm vaccinated, so you know sometimes if I'm not around a lot of people, I'll run with people, walk with people, and I may not have a mask, and that's the risk. But again, if you're outside, but if you like have any, it's good to be around people, and I think these are where at a time people have been making, you know, assessments of their level of risk. So know your level of risk, and know what you're putting yourself into. And like every Monday and Thursday, we lead group runs, and we also have the space, you know, for walkers and walk runners, or run walkers. And so, yeah, if you're not, you know, what we say is if you're not vaccinated, you know, please, you know, join us, because, you know, we're not asking people whether they're vaccinated or not. You should like practice, you know, your level of safety. So if you're not vaccinated, please continue to wear a mask. If you are vaccinated, you know, you can wear a mask, or, you know, if you feel comfortable not wearing a mask, because we meet at different locations in order to spread out, because we're not having en masse, you know, the large group. So we do that in particular just to space everybody out. And so, yeah, we invite you to come. We meet every Monday at 7 p.m. At Marcus Garvey Park, and Thursday the location changes. But yeah, there's a space. If you could walk, definitely come through and join us.
I've personally been to the group many times, and you know, you feel some new life and new community every time. So I strongly encourage it if you're in the Harlem area. And just on the tail end of that discussion, you know, just to also say that, you know, sometimes these feelings of loneliness turn into hopelessness. And if you are developing those types of symptoms, you know, please, you know, there are many different avenues you can reach out to, and we can share in the Q&A local resources for you to reach out to, but please do reach out to your primary care doctor or a local resource for mental health support. So we have time for one more question for Dr. Mack, and this came through via email. Dr. Mack, there's a lot of New York City events that I want to go to. It seems like the city is open again, but is it really safe? Can I go to these events? Do they have to be outdoors? Can I eat at restaurants? Do I have to eat outdoors?
Okay, these are questions that my patients ask me, and yes, it can be safe, but you should really wear a mask, and you should avoid crowds. I really want to go to an event that's happening in Harlem this week, but I just know that it's going to be overrun with people. Everybody may be vaccinated, but I just don't feel comfortable. And so I want people to understand, yes, you can go. Yes, you can go to a restaurant. The restaurants really are practicing social distancing. A lot of them have the partitions up. You take off your mask when you eat. Some places we're checking our temperature. So I think the restaurants are making it safe for us. And again, it's the crowds. You avoid the crowds and wear a mask. And I think you can partake in most of the New York City events that aren't overcrowded.
Thank you. And perhaps just as a follow-up, both for Dr. Mack and Dr. Osorio, if one thing we've learned from this pandemic is we don't know what's coming next. And with the rise of variants and with Delta variant, which I think Dr. Osorio will talk about a little bit more, do you see those recommendations changing in the next days, weeks, months? Or do you think that these sort of standard practices of distancing, avoiding crowds, and wearing a mask should likely be sufficient, even as the variants rise?
I think, and Gina, I'd like to take this first. I think that you have to practice common sense. And so I think you do need to wear a mask. You do need to practice social distancing. And because we don't know what is coming down the pike, things may change and recommendations may change. And if you're not sure, this is where you should make sure that you have a relationship with your doctor so that you can ask them questions. But I think this is one thing that this virus has taught us, that the science helps us to change what we initially may have started and have added things on. And with the variant, the Delta variant, people do not want to get sick again. And so I think the minimum is the mask, avoid crowds, and do the social distancing. And there may be some other things coming down the pike that we don't know about.
So I want to just add, and I always kind of give scenarios or kind of descriptions to my patients to kind of explain, like if you were in a subway car and you have 4 people there, before the ability of the virus to infect others, was very safeguarded with masks. But if you weren't wearing a mask, maybe 1 or 2 would be experiencing symptoms and get infected. With the Delta, unfortunately, what we're seeing is that I'm not going to put you at 100%, everyone's going to get sick, but more people are getting infected in that small area. And so masks are here to stay. I myself never removed my mask. I was like Amir when there was no one around, like maybe a block away, and I was in an open area. Maybe I felt comfortable, and this was during the summers because I know it gets hot. It's about protecting yourself, but it's also about protecting others. We're going to talk about the boosters and who needs them, but understand there's still a lot of little kids, less than 12 years of age who have not been vaccinated. You still have people who are getting treatments either for cancer or other things that make their immune system that not that strong, or you have people who in general don't have a very strong immune system, and they may have gotten the vaccine or maybe not, but in general they may not have been able to make as much proteins or antibodies as someone who their immune system is very strong. So in the future, in terms of the question, in the next few months, I think we're still going to be wearing masks. I think we still have to, as Dr. Mack says, just have common sense and not only think about protecting ourselves, but protecting others. And with that, it's, being mindful that everybody is in a different boat, has had different experiences. So I have patients who have not, don't want to wear the mask or haven't been vaccinated. I kind of try to give them some information, and they know that I'm an infectious disease doctor, so they can ask whatever questions they can. And I think majority do take advantage of that. But I think for me, it's wearing a mask, washing your hands with soap and water. I found it last spring, just anybody who's been my patient for the last 9 years during the flu season, if they did not want the flu vaccine, I would try to push them, but I would be okay. But if you don't want it, please wash your hands with soap and water. Do not touch your face. Now I think that's there now. But understand that the next few months are winter. Flu did not hit New York City that hard, but I think it's because we were all wearing masks and we were still isolating ourselves. Now, people are more open, which I understand why. There's many reasons, but understand flu and other viruses are still out there. And I do know from my pediatric colleagues, they're seeing a lot more, some of the viral illnesses in little kids, like RSV, other viruses that normally would happen. They're seeing that more. And some of it has to do with just not wearing masks as much as we were last year. So I think for right now is protect ourselves. We don't know what's going to happen in the next few months. We haven't known what's been happening with this every day is a day. But the Delta virus for sure is very infectious, and it's something that we just have to be mindful of.
Thank you so much. So I just want to acknowledge there's some really great questions in the Q&A, and we've noted them. And I think that our next panelist is going to be answering quite a few of these. So we'll take a pause from the Q&A, and I just want to introduce the brilliant Dr. Georgina Osorio. You've been hearing from her already this evening. She's an infectious disease specialist based at Mount Sinai Morningside and Mount Sinai West Hospital. She's been heavily engaged with the fight against COVID-19. She's a champion for equitable patient care, and she has been a leader in bringing innovative COVID-19 treatments to our patients. And we're so grateful and lucky to have you here, Dr. Osorio. And I'll have you share your slides as an introduction, and then we'll pick up with the Q&A again.
And I'm mindful of the questions that are coming up, and that was a very generous introduction. And I try not to get too emotional with this, just because it has been a long year and a half. I feel it's been 5 years, but it really hasn't. And part of the reason that I put this up here, I think with every audience, is just understanding where we have come from and where we're at, and just understanding this is 1 year. So what, Dr. Mack already summarized, this was January of 2020 when the first case was known, was December 2019. December 31st, the case was reported to the WHO. Then we have the virus being identified January 2nd of 2020, and pandemic being declared March 11 of 2020. With that, yes, very heavily involved with some of all the clinical trials here at our institution. But understand that with those clinical trials and those studies we were able to do, and really, I myself was the Spanish-speaking investigator, so I was also trying to make sure that all patients had access to these treatments that we were looking at that time. And with that, I was so happy when I heard that one of the treatments that basically we were involved with received federal government emergency use, meaning that now you can use it for treatment and it's not no longer part of a study. And that was May of 2020. And all these other things, you know, people may have heard about plasma and getting proteins that of people who have had the infection and see if that would help. So that received its approval in August. And then you hear about these monoclonal antibodies, and we'll talk a little bit about monoclonal antibodies and what they are. But that was in November 2020. This is the combination that we use here. And then we have our vaccines here that December, where the Pfizer and Moderna vaccines are kind of put in place. And then now we're in January 2021, where Janssen or J&J vaccine then received their approval. And then May, we get our kids above 12 to be able to get their vaccine. Now, July 30th, not that long ago, the same cocktail or monoclonal antibody is now going to be able to be used for people who've been exposed to someone who has COVID, who has not been vaccinated. So you cannot be vaccinated, but it's a way for you to get this treatment if you've been exposed to someone who has had confirmed COVID, and allow your body to get these antibodies to basically so that you don't get as sick as you could be, and give you some protection. That was just July 30th. We now have the booster that was authorized that we'll talk about a little bit in August 12th. And we still have some more things that we have to think about. You know, what's going on with the less than 12 years of age? What's going on for the booster shot for everybody? And some of the everybody, I mean, is even the above 65 years of age. And I'll tell you like why that's important. But again, I'm talking about this is what happened in a year, and this is where we're at now. And this is just right here in August, okay? What vaccines do we have in the United States? I think most of you guys have heard of Moderna, Pfizer, and again, the Johnson Johnson. What's the difference is that the Moderna and Pfizer were made with this RNA that really previous work has been done years before with other viruses. If people are familiar with something called Ebola, a lot of that bench work or clinical research was done with those viruses, so that when this happened, they already had basically the groundwork, and now you basically are launching with all that information. And Moderna and Pfizer are very similar. One doesn't have to be as cold. So the Pfizer usually have to have a very cold freezer. But they're both 2 doses, and one Moderna is 28 days later, you get the second dose. And then for Pfizer, it's 21 days. The booster, we'll talk a little bit about the booster, why there's differences. One is 28 days is going to be the immunocompromised, and we'll define what that means. And then the other is what you're hearing now is this 8 months, how everyone should be getting the booster after 8 months. So approval right now, Moderna is above 18, but Pfizer above 12. And then Johnson Johnson right now, 1 dose for above 18. And how effective, I'll go into it, but you see the percentages here that by the second dose, this is how effective it is to not prevent you from getting COVID, but to give you some protection against COVID so that you don't get that sick enough to get into the hospital or even be in the intensive care unit. And then here, Pfizer, we're at 95%, and we'll talk about what I mean by these titers, what antibodies or proteins mean. And then with Johnson Johnson, you see the numbers here, and some would quote even in the 80s right now. These I don't want you to go into. This is kind of scary looking graph, but don't go into the scary looking graph. All I need you to focus on is this gray number, this gray line are the people that didn't get the vaccine. And we're talking about Moderna here. And this blue line are the people that did get the vaccine. And when the minute, so this is the first dose, this is the second dose. And what they were seeing is who are the people that got infected with COVID. And you see here that the people that did not get, so again, the gray area means placebo, you didn't get the vaccine, are the people that did get infected. And here you see that the people who didn't get the vaccine, who did get the vaccine, there were less instances of people getting COVID. Here is the information for Pfizer. And again, the orange line are the people who got Pfizer, then the blue line are the people who didn't. And again, you see how basically the lines really separate themselves right away. And this information continuously is getting updated. And one of the things that came out with some of the studies is that other studies were looking at people who are immunocompromised. When we say immunocompromised, it means their immune system is not as strong. And it's basically people who have had cancers or have cancer, people who have had a transplant, people are getting treatment that will basically have them take medicine that makes their immune system weaker. People who just don't form enough antibodies, they're born with different syndromes that basically don't allow you to form specific antibodies. And then not people who have HIV, it's people who basically their numbers are so low that they have what's called AIDS, and they have really a very weak immune system. So it's not HIV alone, but it's people who their numbers are basically what we would say less than 200. And then if you're on some medication, because either you have something called rheumatoid arthritis or some other disease that requires you to take medications that make your immune system weaker because you don't want your body to fight itself, those medications would make your immune system weaker. And those are the people that we want to think about giving the booster. And then this is the information for the third dose. And again, this is Pfizer information that just came out. I'll walk through this. So this is the numbers here are basically the amount of proteins that people made. And what you're seeing here, what I want you to think about is that this is the post dose 3. So this is their third dose. So the numbers are falling after their 8th month out after the second vaccine dose. But once they get their third dose or booster, you see that the proteins or the antibodies go up, and they separate it by age just because we know that as we get older, our immune system is weaker. But even for people who are above 65, you see that they form a good response. And this information, really just came out less than a month ago. And this is why you're seeing some of that, the media response regarding the booster. Then they also, that same day, they knew they were going to get asked like what's going on with the Pfizer and how protective it is against the Delta variant, as everybody's is referring it to. And basically what they were able to see is that, yes, it's very effective against the Delta variant. This is the blue that you're seeing here. And if anything, they form a good response. So when you say 11-fold, it just means 11 times higher of the antibody that you're making. So again, yes, protect against the Delta variant as well. What side effects? I'll be honest, I had my second in January, and really what I had, the first dose was just my arm hurt a little bit more than usual from a vaccine. And I'm, infectious disease doctor, and I also was like, oh, it hurts a little bit more than any other vaccine I know of. So that's me just being, and then the second one, the thing that was weird about the second one for me was it wasn't the day of. The day of, I remember maybe 6 hours later, I was like, what's going on? And what I realized is my throat was hurting, and it had been like a year, to be honest, that I hadn't gotten sick. And I didn't really recognize what was going on. And I realized, oh, wait, I'm having a sore throat. And then the next day, that night is when all of a sudden I started having more muscle aches. I would say muscle aches and chills. And that's what I had. But it was the next night. And then by the following morning, which is basically 72 hours later, I was fine. So that was my side effects. I would tell you that my parents, they really just experienced their arm hurting, and they are the type not to tell me when something's wrong, but I would hope that they were honest with me, and they just said that their arm was hurting. What is the Delta variant? I mean, just a little bit, just know that the CDC gives you a lot of information, but this is the most common right now. And you see that this is the orange, this graph is getting higher as the months are kind of going along. Throughout the US, and these are the areas in the United States. And in New York City, it's the same. So in New York City, you're seeing that the orange here is bigger, and so that's the Delta variant. And this is something I already mentioned, but I just want you to be aware about the fact that if you do get any symptoms and you are someone who may have diabetes or other diseases that we know may put you at risk to get sicker with COVID, the first thing you need to do is ask your doctor, where can I get the monoclonal antibody? And this is going to allow you to be able to fight the infection a little bit stronger so you don't get that sick. I put this slide because these are my parents, and just very personal. This was my dad when he got his first shot, and yes, I did cry when this happened. So I was on FaceTime, and this is in Texas where they have to drive in to get it done. And he was very proud that he got the Moderna vaccine, which I told him Fauci got the Moderna vaccine. And then this is my mom, who is a dialysis patient, who I also advocated very strongly for her to get the vaccine. And now the question for her is, when are they going to be able to get the booster in Texas? So I just want to kind of put a little bit of the personal there, and I leave it at that. So
Thank you so much, Dr. Osorio. That was an amazing overview of some very complicated virology and treatments for this really fast-changing virus. And just for the audience, the Delta variant is just one of many, potential variants of this virus, and it's very common for viruses to change a little bit at a time and over time. But this is the one that appears to be the most prevalent at this time, particularly in the United States, of course, where we are, and significantly more infectious than the first, variant that we were experiencing during the first peak last year. So Dr. Osorio, I think you hit on several of the questions, but I wonder if you could do a quick sort of take-home point about this booster vaccine. Many people are vaccinated. They've received 1 or 2 doses of their vaccine. The question is, do we really need the booster vaccine? If so, when is it actually going to be available to us? And who should get it earlier? Who should get it in that first sort of 28 days after vaccination?
So I think we again, it depends on your own immune system. I think that, a lot of the information we're getting from the both vaccines is that over time you do lose the antibody protect, in your blood, so you don't have as much protection. And one of the graphs there showed that within 6 months, some people are going to be lower than others. The priority, or why you're seeing that people with weaker immune systems are getting the boosters first, is because when they got the first 2 shots, they may have had only 40% protection. We may have made 90% proteins, like 90 times more proteins than someone who may not have a strong immune system. So they already started, kind of in the lower end when they got the vaccine. And so the booster for them first is because it's trying to get them to catch up with everybody else. As soon as they get done, I think the next group will probably be the people who are older. So the above 65 years of age, those are the next people. And I think the next will be really everyone else, and, healthcare workers included there, but really everyone else. And I think we're going to hear hopefully more information about this in the next month or 2. I think it's just right now, the focus and what you're seeing with the media, with the people with the decreased immune system, is they didn't launch as fast. And so you want to catch them up right now.
Thanks for clarifying that. Another question for vaccinated individuals. The question is how common is it to get a breakthrough infection? And if you become sick with it, how serious are those infections? And do those patients who have been vaccinated also get these long COVID symptoms that we were talking about previously?
So in terms of breakthrough, they're grabbing that data. It really is less than 1%. CDC really is looking at this, and there's been 166 million people vaccinated, and of those, they report less than 10,000 breakthrough vaccine infections. So I would say less than 1% of those who are vaccinated. But again, some of that is you have to test. So you may have very mild symptoms. You may be having a runny nose, or sore throat. And that's what people have reported with someone who's been vaccinated and may have a breakthrough infection, is it could just be a runny nose. It could be like a headache. You feel more tired than usual. And so do you go get tests? I would tell you in New York City, the amount of testing has really gone down in the last 6 months. So people aren't really going and testing themselves as much. And so if you don't have a test or you don't go to the doctor to see if this is what's going on, then that information is going to be lower than what's being reported. So for right now, with the information that they have, it's really less than 1% of those who are vaccinated have a breakthrough infection with very mild symptoms. And in terms of people having the long COVID, which is what you're hearing, that really is for those individuals who got really sick back in the spring, and it took a while for their body, to really fight the infection. They experienced a lot of inflammation. And so long COVID syndrome that you're hearing is really the people who are trying to recover over time, and their body is just trying to kind of recover from all the inflammation that's going on. So it's not something that you see with someone who has been vaccinated and they get this like breakthrough infection. At this moment in time, it's not something we're seeing.
Thank you. I'm going to combine two questions from the Q&A. For somebody who's already contracted COVID, recovered from it, and was not seriously ill from it, do they still have to take the vaccine? If so, can they just do one dose because they already have their own antibodies? And how long should they wait between getting COVID and getting their vaccine? It's a really great question.
It's a really great question that we were answering. We were thinking about it back even in December when the vaccine came out. So we recommend really within 2 weeks to a month. Most people, depending, if they've been away from isolation, within 2 weeks they got the vaccine. I would say that yes, there is some information that those who were infected with COVID and they get one dose of vaccine, that their body's immune system is able to kind of show, build a lot of antibodies. But that's not something that we recommend. I still think that people should get the two doses, but there is some information that, and again, if this is a generalization, because if you're older, if you already had a weak immune system, you can't assume that because you had COVID that you're going to have a lot of antibodies, and with one dose you're going to do the same thing. So everyone's is very different, and so that's why right now still would recommend the two doses. Still would say about 2 weeks after the infection would be safe for you to get the vaccine.
Terrific, thank you. Another question, and I've heard this from, people in my own circles. I'm pregnant right now, not me personally, your moderator, but this is the person asking the question. My husband's on this call. I'm not pregnant. But this individual says that they are pregnant, and they've been advised to take the vaccine, and they feel uncomfortable with that advice. And they're asking, how could we possibly know so fast that it is safe for people in pregnancy? And I might extend that question to people who want to become pregnant. So is it safe to take during pregnancy, and does it affect fertility?
So this was a question from the very beginning as well, and the Society for the specialty for OB right away said that this was something that they would recommend in the spring. I would say that there have been many, almost millions of individuals who are pregnant who have received the vaccine. I also understand that if unfortunately, there have been individuals who have been pregnant who have been infected with COVID. And the thing is that at that moment, you are not able, being pregnant as alone is already going to be a weak immune system, and you need whatever protection you can get. So I think in general, yes, if you are pregnant, it is safe. There has been no evidence. I know that there's been a lot of attention about fertility being affected with the vaccine, but there really has been no evidence against with that. I actually had a family member mention this to me as well. And I tried to research where this was an original source, and I couldn't find it, but it's definitely no data saying that it affects the either male or female fertility as well. So and so again, right now, if you don't want to get the vaccine, which I do have a few people who do not want to get the vaccine, I again echo what everyone's been saying is wear the mask, be safe. You have to socially isolate, and it's about protecting yourself and others as well.
Thank you so much, Dr. Osorio. We might have a couple more questions for you towards the end, but I'd like to shift gears again and pause our Q&A while I introduce our last panelist. Our third panelist is Dr. Lina Miyakawa, a lung and ICU doctor based at Mount Sinai Beth Israel. Dr. Miyakawa is one of many ICU physicians battling for patients' lives at the forefront of this pandemic. She is an expert educator who teaches both patients and healthcare workers. We're so grateful to have you here, Dr. Miyakawa, and I'll turn over to your slides.
Thank you for having me, and I hope this is informative for everybody. I'm really honored to be here, and I'm so happy that I get to speak to the community because I know that misinformation, there's so much out there, and it's really important to share our thoughts personally, and it's very confusing. So we're here to answer all the questions that are out there. So I showed this graph to show what we did during the pandemic. This is, and I say the pandemic because back in March to May, it was crazy. And we really felt it in the hospitals. And Dr. Mohan Raj is really nodding because we're lung doctors, but we're also ICU doctors. And so we had to put our all into expanding all of our ICUs to be able to handle all the severe COVID patients. So before COVID-19, this is the amount of beds that we had in the ICU. So we had about 24 beds total, and then we had some surgical beds. So total of 32 beds. And after COVID-19, and this we expanded in just one hospital this much over the course of 5 weeks, we had 106 total beds, and we were completely filled. So just on also a personal level, my first intubation, I was actually the ICU attending on when we got our first COVID patient back in March 10th. We didn't have any means of actually checking for COVID. So we had assumed this patient had COVID-19. This patient unfortunately got much worse and had to be intubated. So this top picture here is myself and the ICU director and our respiratory therapist here. We're unfortunately having to intubate her. Now this is our team of doctors. This is who I work with. There's obviously a few people missing, but we all got a lot of support from the community during the time. And these are some headbands that got donated to us to try to keep our hair back during the fights. Much later, and I'll talk a little bit about this, we had our very first successful extubation. So we're talking about 3 to 4 months later, and that was early for this person. This is one of our fellows extubating a patient, getting them off the ventilator. And this is just some pictures of the transformation of the hospital. We had to transform the lobby of the hospital into more ICU beds to be able to accommodate the sheer number of patients that were coming in to the hospital. So you can see from the graphs, this is from New York Times, the reported cases in New York City throughout the pandemic from March to now has gone through some really significant changes. You can see up and down. Unfortunately, there is a rising curve now, likely due to the Delta variant infecting, again, mostly unvaccinated people. And the bottom graph is looking at a slightly different timeline. This is from November 2020 to now, encapsulating mostly this year's data of how many people are hospitalized in the area, which is very different from having positive tests to having severe enough disease that you have to be hospitalized. That's why the graphs look so different. So that's me getting my Pfizer vaccine. My first shot was in December, second shot was in January. So we're talking about these booster shots. Us being on the front lines, we're going to be the first ones to get the booster shots again. Just to kind of talk a little bit more, we really knew back in May. So if you look at this graph, back in May here, the vaccines really changed. Were a game changer, were huge. And Dr. Osorio showed us a graph of when that vaccine came out. We all smiled, right? Because we knew that that was the light at the end of the tunnel for us. And that's really, again, like all of us try not to get emotional, but it was so hard. And that was like our first light. So this last photo, actually also a bright light for me. This is, I work at a post-COVID pulmonary clinic. So we see a lot of patients that have this long haul COVID or people that are still having symptoms. He unfortunately was severely ill, was intubated, unfortunately could not get off the ventilator. So about a month in, we had to do a tracheostomy, which is a hole in the neck, and kept him on the ventilator, the machine. He actually also got a feeding tube in his stomach, and he underwent months and months of rehabilitation. Dr. Mack was kind of talking about pulmonary rehab or going to physical rehab. So he did all of those things. It was a physical and mental toll on him and his family, but after 9 months, after he presented from the hospital to, this is the photo 9 months later, he actually walked into the clinic. This was one of the many miracles of 2020. I wish I had more, but he told me, I'm so lucky to be here. And, but it was really unfortunate. He also told me he lost a lot of loved ones during the course of the year. So let me concentrate a little bit more from the lung standpoint. So I've talked a little bit about the ICU standpoint. So these are from the same person. I'm going to talk you guys through this. These are CT scans. This is a patient I actually took care of. So on the right-hand side is an example of what a normal lung should look like. And this is actually the patient's same scan, but 6 months earlier. He was diagnosed with COVID, got admitted to the hospital, had to be on what we call high flow nasal oxygen, which is oxygen that goes through the nose and gives a lot of pressure. And it sits right here. And he had this CT scan. So this is when he first came in. All of this white here, that's inflammation. We always keep talking about inflammation. What does that look like? This is what it looks like inside the lungs. So some people keep ask me, oh, is that water? So I get that question a lot. It's not necessarily water per se, but if you've ever had a burn on your hand, that's almost like a scar right away. And there's almost like a blister. So that is kind of inflammation, your body getting angry. And so that's what you can see on a CT scan. So this is another different patient that I took care of. Unfortunately, they eventually passed away, had significantly low oxygen levels, required supplemental oxygen throughout their hospital stay. All you can see again is all of this white, a different kind of view at it. But again, a lot of inflammation. So some patients do survive. We've seen that one patient that came back and saw me in clinic, which is great, but many patients that have severe disease really do not. So once you're severe enough and that you need to be intubated or placed on a ventilator, which is a life support machine, the virus has done pretty significant damage to the lungs already, and your body is not able to tolerate all the inflammation in the virus that is causing inside the whole body, not just the lungs, but everywhere. Here again is the same person from earlier. So the first scans that I showed you. On the left-hand side, you can see that the patient has a tube down their airway, which I can show you when it scrolls back. It's this thing here. It's down the airway here. This is the right lung. This is the left lung. The black is air, so outside is air. It's supposed to be, lungs are supposed to be filled with air. So it should be all black, but you can see all of this white. And you can start seeing here, all of this is scarring actually inside the lungs. And so essentially it's the virus destroying the lungs and it's starting to progress. It's causing these tiny little holes throughout the lungs here. He fortunately survived his long stay, was able to come back to the clinic. So again, 9 months later, this is a CT scan that we repeated. He has significant inflammation still, and still a lot of scarring. So this is a lot of holes inside the lungs, but a lot of that white, that inflammation is gone. So thank you again for inviting me to speak today. I know that hearing this information on the news is so different from hearing from people in the community, a friend, or someone that you can trust. And I hope that you are all able to continue this conversation with someone that's knowledgeable about the disease, because I know there's so much misinformation out there. And of course, ask us about the vaccine and any effects. We're here to answer all the questions.
Thanks so much for that overview, Dr. Miyakawa. I think even though I see this every day, I'm still always kind of shocked at how severe the level of inflammation can be in the lungs, how persistent and damaging it can be, but also, you know, with some treatments, and particularly in vaccinated people, how much, you know, sort of, I guess it can improve somewhat, but in vaccinated folks that it's much, much, much less severe. And we see really much less illness in those lungs when people are vaccinated. We have a couple of questions that came via email, and they follow a same theme. So one question is it safe to visit friends and family in the hospital right now? And if I do I have to wear the same gear that I see the doctors wearing and the nurses wearing?
So that's a really good question. Whenever you come into the hospital, I would definitely make sure that you speak to a healthcare provider before seeing your loved ones. They're the best people to make sure that the gear that you have on is the gear that is recommended. Now, for our hospital, we make sure that before you even enter the building, there's a list of questions to make sure that you haven't had any significant exposures or any symptoms that could clue us into an active infection currently. That's because we want to make sure that we protect all the patients in the hospital that could be at risk for getting severe COVID. So those are the patients that we talked about earlier that have active cancer, undergoing chemotherapy. And so if you're feeling sick at all, and it may not even be COVID, it may be some other virus, we want to make sure that we protect your loved ones and all the other communities' loved ones. When you're going into the room, there's two kind of big arms here. The one arm is if they're not on ventilator, if they're on other modes of oxygen. I earlier mentioned a high flow nasal oxygen or a BiPAP, which is a mask that blows air into the face. Some of those will actually disperse virus into the air. And so we don't recommend people going into the room. And again, I know this adds to so much anxiety for patients and loved ones to not be able to hold their loved one's hand. But it's to protect you yourself when you're visiting, and also, again, people around you. But if they're on the ventilator or if they're not on any oxygen, you actually can go in the room because the virus is not being in the air, because the ventilator is actually what we call closed circuit. It all stays inside the lungs and in the ventilator, which is the machine. When you're going in the room, we do recommend a mask, a surgical mask. We provide that. You do not need the gear that you see us wearing, which is the N95 mask. And that's because N95 masks, there's different sizes, different types. You actually have to be fitted for them. So if you're wearing it wrong, actually it harms you because you think you're protected, and then you could have had a bad exposure that you could then bring home to your kids, your elderly parents, people that may be more at risk than you are. Okay. So mask, eyewear, and then a gown and gloves. And obviously washing your hands before and after is very, very big, because there's other viruses out there in the world other than COVID.
Fantastic, thank you. And again, along those lines, but maybe a little bit more personal, is that one audience member says that they have asthma, and before COVID, they used to go to the emergency room frequently, but now they're afraid to get COVID if they go to the hospital. Is it safe to go to the emergency room these days? If I have to go, how do I protect myself? Or should I just avoid the ER completely and just talk to my doctor as an outpatient?
So I think we all in New York experienced such a heightened sense of, we were all so scared to go into the hospitals, and we were turning patients away. We're telling people not to come into the hospital, right? This is back in March, April. And that was, the first time in many, 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 many years, if ever, right, that physicians were doing that. That's not the case anymore. We want to make sure that we can still treat all the illnesses so that we can make sure you're healthy so that you don't get COVID. And so that's important. So if you need to go to the emergency room because your oxygen's too low, you can't breathe, we still want you to come in, and we have ways to make sure that you don't get COVID or there's less exposure. Of course, I can't guarantee anything, but for you, same thing, washing your hands, wearing a mask, keeping a distance. I think those are going to be the main things to try to prevent you from coming into the hospital or the emergency room. Having very close follow-up, or having an open line of communication, like Dr. Mack said earlier, with your physicians, your primary care doctors, your trusted lung doctors, right? And so I think that's really important, because the clinics will have less sick people around, right? And so it's all about balancing risk versus benefit and knowing what your risks are.
Yeah, and if I could share, because I have a 2-year-old son, so like I've actually had to go to the emergency room like twice. So I know from firsthand experience that like when you gotta go, you gotta go. So when we went, the same thing, ethanol everywhere, wash your hands, and we wore masks. So, you gotta do what you gotta do, and I'm glad we were able to go. So.
Thank you for sharing that. And we've been in the same experience as well as patients. I'm taking off my doctor hat here. But I do want to emphasize and echo really what you both said. We know a lot more now than we did in March and April. We know so much more. And we have very strict and very safe protocols in place, and all of those, and it's not just in Mount Sinai Hospital system, it's in all the hospitals throughout New York City. Waiting rooms are distanced. Everybody is ensured to be wearing a mask. There are protocols in place to make sure that you are sharing very little air with the people around you. Unlike last year, when we had to cancel a lot of elective procedures and close down primary care offices, we really have the opportunity now to see all of our patients, not just with COVID, but with any type of disease processes. The other thing I might add is that the other thing we've learned is how to use Zoom. And doctors have become great at this. I think it's most important to communicate with your primary care doctor about what is safe to see them over Zoom for and what you need to actually come in person for. But your doctor can guide you about that and give you that information. And of course, in any emergency situation, I think everyone on this call, I hope, knows in a true emergency, of course, you'll be dialing 911 and brought safely to the hospital, or find a way to transport yourself to an emergency room if it's truly an emergency. I think this has been such a great discussion. We only have time for 2 more questions. So one more for Dr. Miyakawa. So there's rumors out there that once you get COVID, if you're put on a ventilator, things get worse and that you're likely going to die. If I or someone I know get very sick with COVID, should we refuse a ventilator?
So that's a question we've gotten several times, myself personally. And it's a really good question, something really good to talk about, because I think what we do in the ICU is not something that's talked about very frequently. And especially during the pandemic, a lot has come to light, but it's still very new for people that have never experienced the ICU. It's a place where very, very sick people go. So when somebody that comes to the emergency room or the hospital, if they get sicker, there's other things that are life supporting that we can do in the ICU to keep people alive. Now, not everything that we do in the ICU works. It's to try to help the body recover. Sometimes the body is too sick for us to salvage the organs that have already been injured. So I say that because with COVID, depending on how severe the inflammation has been, how long the virus has been ravaging someone's body, it's really hard for us to try to come back from that. And so I think, again, I'm going to harp on this some more. We've learned so much in the last year. Yes, there's so much we still don't know, but so much we've learned. And how we were able to treat patients back in March of last year compared to now is so different. And I know that there's a lot of rumors about being placed on a ventilator and then dying back then. There have been people like the photo that I showed you of a patient getting intubated, getting a tracheostomy, going through rehab, and then being able to come back to clinic. So it is not, and I'm going to use very frank, plain language, it's not a death sentence to be placed on a life support machine or the ventilator. But it does mean that you're very sick. It's not the ventilator that kills patients. It's actually the virus, and we're still trying to support the body through that with the life support machine. But sometimes it could be too late, even though everybody came in when they should, and we did all the right stuff. Sometimes people are just too sick and the virus is too strong. And that's why we really, really are saying the vaccine is the way to go, because it actually prevents this severe disease being on the ventilator or getting placed on the ventilator. So to answer the question more close, or to in a more straight manner, don't refuse the ventilator. We're trying to help you, and just ask questions. Ask us why. Why is it that the patient needs the ventilator? What are you worried about? Sometimes it is an emergency. I've had a patient's family member ask me months later, but they came in and they asked me, why didn't you have my husband call me before you intubated him? So intubations sometimes are emergent. It happens if someone isn't having or is not able to take in enough air, their oxygen levels can drop very suddenly and it becomes an emergency. And we have to save that person's life and put the tube in immediately. Sometimes we have a little bit more time. Just yesterday, I called every single family member in California because this patient was visiting, actually. So we had called 5 children on FaceTime before we were able to intubate the patient. So it's a very wide range, and we're here to try to respect everyone's wishes and make sure that we're doing all the right stuff.
I love how you describe that wide range and respect, Dr. Miyakawa. And I think really it's what we pride ourselves on as physicians is helping patients and guiding patients towards decisions that are based on your values, your health story, your personal story, your religious values, your spiritual values, your family connections. And we really try to take the time when we can to work with you to take that into account for any health decision. It may be something as big as an intubation or as big as taking a vaccine. It may be something much smaller, but we really try to keep it centered to you, to our patients when we're trying to work through these decisions. So I wish we had hours and hours to continue this. So many amazing questions and great responses from our panelists. I'm going to end on a tough question, and I might direct this one first to Dr. Osorio, but certainly ask others to pipe in. I wrestle with this question myself because it's happened to me personally on more than one occasion. But this audience member says, I have friends and family who refuse to get vaccinated. How can I convince them to get vaccinated?
I think, I mean, that's a very tough question in general, because I think I've gotten different approaches. I've have a niece who is 23, who is the only immediate family member who's not vaccinated. She, I think very progressive, but believes that there's a chip in the vaccine. And I explain the information to her. I give her, some of the information that I presented, and they know what I've gone through the last year and a half. They've heard stories, they've heard patient stories, and the main thing that she does is she's very mindful that she's going to wear a mask. Like, this is just something that she doesn't want to do. She doesn't want to have it be in her body. She is aware that my parents need it, my nephew, nieces, things like that, but she herself just does not want to. And so I'm there answering questions. I don't push her, like, and hopefully at some point she will. But the main thing I stress to her is to protect herself. I just said what I've been doing for 9 years for the flu vaccine. If you wash your hands with soap and water, don't touch your face. Same thing with her, is being mindful of who she's around, being mindful if she's sick, also isolating herself. Regarding my patients, we had different ways. I've had in the beginning older individuals who were, where we were having difficulty getting appointments in the beginning, and now, they're all vaccinated. So we had the wave of people running to get this vaccine. And then I have people, I would say less than five, to be honest. And my patient population is all through the Harlem area, Spanish speaking, Hispanic, Latinos, and African Americans. So everywhere, French speaking, West African. And what happened with me is, I gave them the information. I had space carved out with each visit to allow them to ask questions. They knew that I was an infectious disease doctor. I think they came prepared for questions. They even talked to me about what they've heard and what their family has said. But every time I went into a room, it was a different experience. It was people that were mentioned already who lost a lot of family members. It was individuals themselves who have gotten very sick. It's individuals who have had a lot of anxiety and trauma and from being alone. And so you had groups that were running to go get the vaccines. And then I have about five people that don't want it for different reasons. And what I did back in like late spring is, and I did it, I said it from my heart, because they know me. They know that we really, we connect. They really are like, I treat them just as I would treat a family member. And I was very honest with them. I had just finished service in the hospital as an infectious disease doctor. And I was letting them know, look, I just don't want, I understand and I respect your decision, but I don't want to have to visit you in the hospital very sick. And in my head, I feel bad or guilty that I didn't push you, like I didn't try. And then, no, don't worry, Dr. Sarah, will be fine. They'll be fine. I'll be safe. I'm going to wear a mask. Don't worry about me. And then I said, okay. And then I'll answer a few questions that they'll have. And at that moment, I said, okay, at this point, I'll put on here that we talked about it, but just know that if you need it, if you ever change your mind, if you have any other questions, I'm here. We can schedule it right away. We can even put you in, in the elevator and get you in to get it. So, and that's what my patients know. And again, it's different extremes. We had the people who were running to get the vaccine that were not able to do it on the internet. So I was creating email addresses so that they can get it scheduled, or having them go, with someone's help to the place where they can get the vaccine. And then you have the people that are kind of waiting. And I would say it's all ages. There's not a specific age. I mentioned my niece, but it's actually older to very young that have, said, I just don't want it. But they all stress to me, I'm going to wear my vaccine. I'm just going to continue. I'm going to wear my mask. And I'm just going to continue doing what I'm doing, which is be safe and protect myself. And that, at least makes, they comfort me saying, I'm going to be safe, Dr. Osorio. So that's what I would say. I think it's just an ongoing conversation, being open, being respectful of someone's decision, and allowing them to have the information that they need to make an informed decision. Because in the end, it's their decision. It's not my decision. And I think for me, it was just when I was seeing people in the hospital again in the spring, I just needed to let them know, look, like it's here. Dr. and all the doctors know that we were all crying. I will be honest. I even mentioned to the person who gave it to me, I thought I was going to get treatment for COVID. I never thought I would get something to protect me. Everyone knew what I wanted. I didn't want this. I wanted this. And when I got the first shot, I just was not expecting it. And my patients know what we've gone through. And I think that's where it's a little bit different, because they know that we're infectious disease doctors. But that's what I would say is be respectful, keep the conversation going, allow people to ask questions. And in the end, it's that person's decision. And in the end, it's being safe for yourself, but for others by continuing to wear masks, regardless of your decision as well.
That was so beautifully put, Dr. Osorio. Respectful perseverance. From my perspective, I've had some success stories of people I love, people I know who have had, vaccine hesitancy, and some relationships I'm still working on. Really respecting people's autonomy, their right to make their own choices, but putting it into the context of this larger world where we are all responsible for each other, for ourselves, but also for each other. So thank you for phrasing that so well. Well, we've come to the end of our evening. And first and foremost, thank you to our amazing panelists. Thank you for giving up of your time, your knowledge, your expertise, and really doing so humanistically. I feel very lucky to work with all of you, and so proud that you are the caregivers and the community leaders for our community, especially here in Harlem. Thank you so much. To all our registered audience members and everybody who logged on tonight, thank you so much for sharing your time with us, for keeping open minds and bringing such fantastic questions. I think this conversation will continue, and we feel very honored and grateful to be trusted to be in this space, and we would love to continue these conversations. And with that, we're just very excited that our partnership between physicians and healthcare workers at Mount Sinai and with Harlem Run is going to continue. So we ask you to look forward for more community education webinars that are related to health and wellness. And we're also really excited in September, we're going to launch an initiative called Walk Together, Talk Together. We're all cheering. We're really excited about this, where the Monday night walking groups that are run by Harlem Run, we're going to join for that. We have a long history of providing amazing healthcare to this community, but it's often that we're bringing patients to us into our space. And we thought it was about time that we come into your space. So we're really excited about that, to get to know you. We're ditching the white coats. And we just want to walk with you and get to know all of you as people, neighbors, and friends. So we can't wait. We hope that you'll join the Monday night groups and look to this, the Harlem Run space on social media to hear more about it. And please do reach out to us if you have any questions. With that, I'll say goodnight. Please be safe, everybody. Wear your masks, keep your distance, please get vaccinated, and talk to your doctor if you have any additional questions. Have a great night.